The common symptoms of IPF include a dry cough. This can be a chronic hacking dry cough. In about 10 to 15% of cases, this is the only symptom, and it can predate the onset of the shortness of breath. So when a clinician is faced with a chronic cough, things they typically think of might be asthma, might be a postnasal drip, might be gastroesophageal reflux disease, might be bronchitis. So it's easy to understand why patients will go misdiagnosed if they present only with a chronic cough. Dyspnea, I alluded to already in terms of competing with COPD, heart failure, asthma, deconditioning. All of these things can present with dyspnea. Fatigue is usually more of a late-term type of presentation. When the patient starts to desaturate, then they might develop some fatigue associated with this as well. And what can happen in any patient with any disease who has shortness of breath, they tend to do less. The less they do, the more fatigued they become deconditioned, and they're getting to the spiral of shortness of breath, leading to more fatigue, leading to further deconditioning. Exercise desaturation invariably sets in as the disease progresses. And a big clue on physical exam is the presence of bibasilar inspiratory crackles, which have been described as Velcro-like in nature because they sound like Velcro being pulled apart. It's unusual, but you can see clubbing of the fingers. This is a fairly nonspecific sign, can be seen in other conditions as well. And I think today we're seeing less clubbing as we pick up on hypoxemia earlier than we did perhaps 20 or 30 years ago.